And thank you so much for the invitation. Thank you so much also for the extra motivation that I got from your invitation and from the fact that I totally, with all my heart, agreed to be with you guys in this morning because for a couple of 2 weeks almost, I'm fighting with a terrible flu, and unfortunately, I'm in fashion, let's say, with this problem. But you are, as I was saying, my motivation to be well today and to recover. I will do my best to be in my best shape. But please, whenever you feel comfortable, whenever you want to stop me and ask me something, I think you are allowed, but my colleague from Smart Aligner Service will tell me, or we can save some extra time at the end to clarify everything and to go again through the presentation. And in this way, everyone will be will go home with, I hope, extra knowledge. My name is, as you already know, is Elvira Patroi, and I would like to introduce myself to tell you a couple of things of my past ortho experience. I worked only in orthodontics, and I graduated the College of Bucharest in Romania since 2011. I probably can say that I graduated the course, the FACE course, the Functional and Cosmetic Expertise course with Dr. Domingo and Alberto Canabes. But at the point where everything shifted and changed was a couple of years, of course, like many of you, most probably, during the pandemic time, because since then, since 2020, I seriously started to learn about the ortho treatments with aligners. And since 2022, when I became a mother, I decided that this is the best practice, not only for us as doctors, but also for our patients, and all the reasons why. In 2022, I founded Romanian Society for Aligners because countries like Turkey, like Germany, like Italy, Spain, also Portugal were my examples in becoming a role, not a role model, but in sharing all my knowledge and in sharing all of the doctors in gathering together in a professional society, just like Smart Aligner Services. In this point, I would like to congratulate all the guys from Smart Aligner Services about their whole activity, because I know how hard it is to organize courses, and they did an amazing job this past year and a half or 2 years. I don't know exactly the time that they founded, but they're doing an extremely good job in providing us, all the doctors, all the top knowledge from the speakers worldwide. So thank you also for this, and congratulations, all of you guys. Since almost 2 years, I can say, I shared my expertise, my knowledge, and my cases with a lot of tips and tricks and a lot of videos to all of those that offer me their time and, of course, their attention. A couple of images from Bucharest I would like to see and to invite you. You are invited, and you are invited not only in Bucharest, but you are invited also into my clinic. If you like to come for a couple of days or for one day in my office, I would gladly and warmly receive you among my colleagues and to see patients, to discuss clean checks or some other techniques that maybe you want to improve and that I can help you with. But let's think about the cases that we most probably all started. A briefly case selection would be the ones that we can easily try to convince our patients, and that it's easy for them to understand, but also it's easy for us to to understand and to apply the biomechanics. So I would say that a class 3 minimum with a minimum overbite and overjet and no extractions needed is a good starting point. And also the deep bite and open bite cases, but pay attention in order to not to be a severe one. And of course, in the college years, we have studied and learned about the classifications. Lower incisors extractions are also apparently a very good starting point also. But I could say that in our country and in the Eastern European countries, most people face with this type of anomaly of a problem, a class 2, a second class with second class minor crowding. So we are somehow obliged to learn about this. What really convinced me to shift my practice from a mixed one to an only aligner practice? Well, of course, we are in our life, we are faced with problems that oblige us to adapt, to change, to learn more, and every day is an opportunity for this. In 2000, before the pandemic, as I remember, in February or even January, my corporate patient, I say this corporate because they have this very strict and control freak, let's say, mindset. And she told me from the start that she wants straight teeth, spectacular white teeth. She wants the smile that she dreamed of since she was born. And she wants that type of smile, very fast, very comfortable, and mostly by the end of the year, because she wants to become a mother and she wants to finish with this process, with this teeth preparation process before becoming pregnant, before becoming a mother. So, as we all know, sometimes, and most of the time, actually, life is not actually a fairy tale. And if you lose your shoe at midnight, you are drunk, let's say. But I could not say this to my patient. I could not say that maybe at that time I wasn't that well qualified in order to achieve all of this. Not only the change of the position of her teeth, but also to modify the color, the shape, to modify her smile totally. But, well, here she is. But she has a nice personality, and I told her that yes, I will. I could do that. I will talk with my colleague, with the prosthodontist, and we will see what we can do. And I will do my best to finish in a couple of months, to finish this year as you want. And I performed the photos, the extra photos, extra oral photos. And as we can see, there's an uneven buccal corridors, asymmetric buccal corridors, because on the right side, the buccal corridor is it's bigger than the right one. And the deep bite, we can notice the crowding, that it's somehow small to moderate on the upper, but severe on the lower. We see it better in this photo, in this image. There's a big problem from the medical criteria, from the functional criteria of the deep speaker, and we have to take this into consideration. She has class 1 canine and molar bilateral, and of course we have to in this aligner ortho treatment, we have to think about the midlines and to notice from the beginning what midline is centered with the middle of the face, because as we all know, it's not an issue, it's not a medical problem if the upper doesn't coincidence, isn't centered with the lower midline, but it's very important that the upper midline should be centered, should be on the same axis with the middle of the face. So we saw that it is her case that the lower midline is shifted towards the right, and we will try to correct this in our treatment. These are the occlusal images where we can notice the lack of space for 43, and also the fact that on the upper side, on the maxilla, the maxilla, the arch is not that constricted as we could see it from the beginning. I did the analysis in Dolphin of the tela because I always perform it in the program. Maybe it's not a good idea to do some advertising commercial here, but the important thing is that she's a normal divergent. She's a normal divergent skeletal class. She's class 1 skeletal, and the maxilla and the mandible are well developed. From the OPG, unfortunately, we can notice that due to the severe crowding on the lower frontal teeth, the resorption is pronounced for her age because she's a 30 years old female. Fortunately, there are no wisdom teeth. And because I get enough of exercise whenever I push my luck, and sometimes women are less fortunate than men, I talked with my colleague, the prosthodontics, and because you all know that ortho goes so well, goes so well hand in hand with the prosto part, I married the prosthodontics, but this is not the topic here. The idea is the fact that whenever we face this type of treatment, the multidisciplinary treatment, we have to analyze the case from the third dimension, from the vertical, sagittal, and from the transversal one, because it's very important to follow this scheme, is to follow this type of mindset whenever we analyze the clean check or the digital treatment plan. I always perform the temporary retention with a fixed one on the lower, and with a simple S6 plastic removable retainer done in my office for the 2 weeks or 1 month period. It doesn't matter how much the prosthodontic will do his job. And after we finish the whole treatment, there will be put a fixed retainer, maybe another one. It depends on the structure, and also the professional retainers. The pre-restorative ortho liner treatment had these specific goals, all of them very, very important. And besides the alignment of the teeth and the leveling of the gingival margins that I'm sure you all know, very important is that we have to coordinate the arches and to make IPR from 3 to 3 to provide a proper overjet. This is very important in all the multidisciplinary cases, because we have to do the expansion, the lower incisor IPR, and the retraction, because we have to ensure that the prosthodontic will have enough space for the ceramic crowns or veneers. We have to center the teeth in the medullar bone, because otherwise in a couple of years we will notice gingival recessions, and you will see at the end, as a spoiler alert, that we did also the follow-up of this case, and the result is amazing through the years. And we have to coordinate the arches. Very important of this case is to do the symmetrical expansion, although As you saw from the beginning in the facial, in the extraoral photos, the buccal corridors were uneven. One was bigger and the other one was smaller. Here are the guidelines for the dental technician, for the CAD designer. And I like to share, as I told my colleague from SaaS services, that I like to openly share my perspective in following this ortho aligner treatment. So even from the beginning, I told the patient that I advised her to perform an extraction of tooth 42, but she didn't agree. So I told the CAD designer to make unmovable the second upper molars, to have them as anchorage and to expand according to them. Also, I told that the veneers will be put from 15 to 25, and that is very important to lower the IPR on the lower frontal teeth, not to put it on 0.5 but on 0.4, because there will be no extractions. I will tell you this, 0.5, I do it very, very rare, and 0.5 is a sum of IPR that I always do it whenever I need it, but always on the posterior side, on the posterior sectors, not on the frontal one, and not from the beginning. But because I knew from the beginning that she will have veneers, I agreed with this big type of IPR. Here is the digital treatment plan, and even though now I can admit and tell you that I would use another type of attachments, not these optimized attachments, I should say or should not say that I'm a very big fan of conventional big attachments. Put it on the frontal upper teeth in order to control the torque of the expression of the torque of the teeth, and also for the retention in the upper lateral sectors. As you can see, there is a power reach on the lower, on 42, on tooth 42, and this is very important, because even though I do not use, I never use power ridges on the upper, I use every time it is needed on the lower incisors. Let's see the treatment plan, the digital treatment plan from the occlusal side. And you can notice that the CAD designer respected my desire of unmoving the upper second molars and to expand the whole arch according to them. And you can see that the retraction was done partially in order to create the space we need at the end. This is the end of the aligner treatment. And if it wasn't for the lower arch, where of course I performed, as I told you, a very invasive and big type of IPR that I would never do it in a regular case, in a regular ortho case, the upper arch is looking much better. Her appearance is improved. The buccal corridors, due to the symmetrical expansion, not unsymmetrical, but symmetrical expansion, is looking much better. You can see it also here from the start of the prostate treatment. You can now see better the interproximal cavities and stains that she had. So this explains the fact that she wanted another a type of treatment, a second type of treatment with prosto and with changing her shape and the color. We can see here that the mock-up of the teeth, we will see actually better in the following slides, but what I wanted to tell you that in my perspective, at the beginning was a little bit too much to put from premolar second to the second premolar, from upper, lower, left, right side, to put in all of her teeth IPS MX veneers. But as I secondly understood, her smile is a very big one, is a very wide one, and the aesthetic protocol in prosthodontics require this type of preparation. Here is the invasive IPR, as I told you, and this is the final position also. Spaces were left here in order to provide the necessary width of the ceramics, and also no spaces were needed, and this is very important. No spaces were needed in the upper arch because her teeth are very wide, and the prosto didn't need to do an extra preparation for this type of teeth. This is the before, this is the after, the comparison between the two type of arches, the two type of upper arches. And let us see again the fact that on the lower part, the size and the shape of tooth 32nd has on the distal side an extra cavity that was discovered when we did that extra IPR. This is the before and the after on the aligner ortho treatment. And this is the mock-up from the aesthetic testing. We analyze on the mock-up, as you already know, we analyze the shape, the length, the width of the incisors, the premolars, the canines, of course. But please pay attention to this very important thing, that the mock-up has been done with the attachments on. Because if, for example, a patient had another desire, or the prosto would see something that would need to change, also I would have to change the digital treatment plan and to do an additional aligner treatment. But this is one of the reasons that convinced me to shift, as I told you, from a classical mixed ortho practice to ortho exclusive aligner practice, because all of these cases, all of the cases for preparing patients for prosto treatments are done with only an additional, with only a set of aligners, not one additional set. This is the mock-up, as I was mentioning, but this is also the aspect seen from the functional point of view. Here is tested the protrusion and the lateral movements, the eccentric movements, and a good comparison between the initial after ortho and also the mock-up. Here is the upper and lower jaw preparations, all done in one single appointment, as being done in a non-invasive type of preparing them with a MIP, as you already know, minimal invasive preparation. I repeat, they could be done in the same appointment. At that time, I wasn't using with my colleague the digital workflow, unfortunately. Now it's a totally different thing. We used back then analog impressions with polyether for the dental arches impression, and of course for the bite registration, a silicone one. And this is the final outcome, the result, and is amazingly natural and a total different person. She was and is a very happy mother and woman. Um, as you can see, of course, the color of the first and second molar is the old one. The yellow one of first class molar was maintained, and now the interincisal lines are centered, which is very important also for the maximum aesthetic of the patients. Here's also the final result with the deep SPI curve corrected from the occlusal side, and this is the comparison before, after ortho, and after prosto. And this is, as I was mentioning, the 4 years follow-up photos. And even though you could see, honestly, a very small gingival recession, they may seem like gingival recession on the lower left side, but they aren't really recessions. They are preparations done only in the enamel, preparations done by my colleague who consider that it's better to do it in this way, only in the enamel, not on the dentin surface, because the aesthetics on this sector isn't that high. And here is the occlusal view. And to sum up, in 8 months total treatment time, I satisfied all her desires and wishes to have the smile of her life in less than 1 year, and to start the preparations for becoming a mother, which she succeeded, of course. And I'm totally happy for her. Now we go together in the park with our children. With only 7 months of ortholiner treatments and one set, as I was telling, 10 days change interval, no additional aligners were requested, and 1 month of prosto work. Please keep in mind that minimal invasive preparations were performed, but only because we succeeded to accomplish the overbite and overjet requested in this type of cases. Pre-restorative ortho treatment with aligners, and just to review a little bit, of course, they're very fast, they're very easy, very comfortable treatments for our patients. And for us doctors, as orthodontists, I mean, it's less and more flexible work, as you know, but it's less work because we, in most of the cases, when we know how to prepare those cases, we are not faced with the problem of additional aligners, which we all know that we all desire to have no additional aligners needed. For the prosthodontist or the referral dentist, is a very happy situation to early start the restorative treatment, not only from the financial point of view, but also from the point of view of the patient's satisfaction. And please not forget, please keep in mind that always aligners will represent a method, a way of treatment, and not a product, not a service that all the big marketing brands are trying to emphasize. And we have to respect the ortho basic ground rules that were taught us in the college years and in the residency years, and from all our big mentors that each of us had. And yes, if it doesn't challenge you, it doesn't change you. And I'm a very big fan of changes and of adapting process. And I'm sure that being with me today, this morning, you are also, and I congratulate you for this. Let's talk a little bit about the theoretical part. And I don't know if you are aware of this, but it's a difference between what we consider the classical overjet and what the brands of aligners consider overjet, what actually the CAD designers consider the proper overjet. So from our point of view, from the orthodontist point of view, the overjet is between, as you all know, from the exterior surface of the lower frontal teeth to the internal or labial side of upper frontal teeth. But for CAD designers is from the lower teeth to the half width of the upper teeth. So make sure to add an extra 0.5 millimeters. Remember also the pearl necklace effect. And as you all know, whenever we try to expand the posterior and the middle part of the arches, always there will be a natural arc depth loss for 1 millimeter. It happened to me, guys, and I was really, really shocked about this, that I sincerely and honestly share with you the fact that I had a very nice and important person, very important patient, let's say, that was very upset to me at the end of her ortho treatment. She considered the end of the ortho treatment because she is a public figure in our country and told me that her appearance is all changed due to this natural arc depth loss. Of course, in my opinion, it's a very small change, 1 millimeter, but for her, apparently is a very big issue. Now I'm in the process of correcting it, and hopefully she will be satisfied at the end. But now I want to talk about a very delicate situation. Let's imagine, let's think about the cases that most frequently happen to you also, to receive at the first consultation patients that were treated in other clinics, that were treated by other doctors, and they are not satisfied, they are not happy with their past ortho treatment. And this is the case of my patient. Please take a look at her facial extraoral appearance, because not only the shifted interincisal line, but the fact that she presents crossbite on her right side, it changes her whole appearance. As I told you, every time I perform the analysis of the teller, and you can see the tracing here. And this is the way how she came into my clinic at the first consultation with braces that were left there in order to maintain the spaces for the implants. As you all know, this is the process, the classical process, whenever we are treating patients with braces. But let's take a good look at the crossbites, as I was telling you. Let's take a good look at the recessions and at the edge-to-edge part on the right side, and the fact that it's uneven gingival margins. She had a fixed retention, a fixed retainer on the upper side. And what is the big mistake made on this case? The fact that the dental implants were put, please take a look, at before the end of the ortho treatment. From my perspective, and I'm sure that in yours also, the ortho treatment wouldn't supposed to finish in this way, but I know that we all orthodontists do our best whenever we treat our patients, but somehow this type of problem appear. So besides what we were seeing, what we were looking at, we face with a 47
tooth inclined not only in the mesial side, but only in the lingual side. And the major disadvantage of this type of treatment, as I was mentioning, is the fact that the implant for tooth 26 was performed before the end of the treatment. So my objectives for the pre-restorative ortho aligner treatment was to upright 47 was to pay attention to selective stationary stations in order to provide enough anchorage for the correction of the crossbites and to improve the correlation of the midlines. Why I say improving and not correcting? Because from the beginning, my patient said that she wants a very fast, a very efficient treatment, that she's is very tired from the ortho treatment, the whole process, and she wants to move on as fast as possible to the prosto part. And I totally understood her, of course. And here are the guidelines for the technicians. These are the most important. This is the most important slide in my perspective for this patient. And let's try to review it together. To start the upright of 47 with a distal crown tip plus constriction towards the lingual to correct the crossbite. Please don't forget to place an yin-yang attachment on big molars whenever we are trying to put on them big movements, and to hold stationary some parts for that big anchorage that we need. Very important to constrict 44, for example, of course, to correct the crossbite, but to hold it stationary during the treatment. And a very, very important thing that helped me with this type of treatment in achieving a very good result is the fact that I asked the CAD designer to put a semi-pontic on 46 and to shrink it, to constrict that semi-pontic in order to have as much plastic on proximal surfaces as possible. This is very, very important in assuring that this tooth will correct. This is the digital treatment plan. And I wanted you to review it and to evaluate as I did, and to make sure that every time you will verify the guidelines that you are telling the technician to what you are receiving, not only from the comments section, but of course from taking a very good look at the digital treatment plan. And please do not forget to maximize the image, to put it on the maximum possible, especially for the sections that you know it's important to correct. For example, the cross bites. So here's the big outcome after one set of aligners. Besides the fact that unfortunately 47 wasn't totally corrected, but I was assured by my colleague, the prosthodontics, that he will put it in a very functional, stable, most important position with the help of the crown. This is the result from that one set, that unique set of aligners from the occlusal side. The alignment was accomplished. The space was also provided for the crown that was put on the implant for 26. Very, very important, because maybe you will remember that at the beginning, the space for 26, the space for the crown on 26 on the distal side, it wasn't enough. And of course, it was impossible for the prosto to perform a proper crown from the strength point of view. They have to ensure the same width of the ceramic on the whole crown, of course. And this was accomplished due to our treatment that lasted for, as I remember, 11 months. We will confirm it very soon. Why say it's a compromise? Because if the patient would have allowed me and would have accepted another set of aligners, I would definitely, in a classical, in a regular type of ortho treatment, I would try to correct more the crown inclination, the crown torque of 47, and the crown torque of course, of 16, in providing extra buccal crown torque and to correct this. But it wasn't an option because she was very happy with the fact that her appearance was centered, so she was looking much better, and finally my colleague could put the crowns on her implants, and I succeeded in improving the midlines in of course, you probably can imagine and explain to yourself that this improvement was done by the help of the correction of the crossbites on the right side, and this is the final outcome of also from the prosto point of view. And what is very, very important to tell and to share with all of you guys, and hopefully my future friends, is the fact that these crowns that were put by my colleague, the prostodontist, are screw-retained implant crowns. What does it mean? That if let's say, in the worst case scenario, some small gingival recessions will occur, or if there won't be a stable result, if some minor crossbite will appear on the posterior right side, then he could unscrew the crowns, and I would, of course, could perform another set of additional aligners whenever she would agree, because of course now she's more relaxed, she's more happy with the way she's smiling. So this is a very important aspect that you could tell your referral dentist to use this type of crowns. Why I say that I like to think that you're my future friends, because I hope to meet all of you at the Smart Aligner Services workshop that will be done on the Thursday next week, right? And we can all meet there and to attend and to share our opinions and advices, and to meet all of you. This is after the ortho and prosto, as I was mentioning, the fact that you can see here those special type of crowns is also a more clarifying and explaining way of remaining with this case. And to sum up, on 1 year total treatment time was done, and I could say that is acceptable, is something that we could consider as normal or bearable from my point of view, because I always try to put myself in the patient's shoes, let's say, and with 2 weeks of prosto work only for the crowns, and with 11 months, as I was saying, ortholiner treatment, the whole process was achieved. But this is a similar and very special case, because the funny thing is that the whole treatment with ortho and prosto lasted for 10 months, I could say, the whole process. And after our treatment, she became a mother. She was pregnant, and 9 months for her baby waiting, and almost 10 months for the transformation of her smile, because as you can see, is not in her best appearance. Was really amazing. She came like this in my office with this. We did of course the OPG, and we could see from here that she had also classical ortho treatment with braces, and there is not enough space for the crowns on the lateral incisors. Why is not enough space? Because the one in the a 12 for the 12 tooth is bigger than the one for 22, and the aesthetic would be, oh my God, you can only imagine. There is not enough space for the crown on the implant for 16, but fortunately wisdom teeth are not present. Let's look also on the bright side of the case of the things. On the CEF, you can see the implants, the proclination, the big proclination done with braces, because unfortunately we can't control the proclination, the expansion on this classical type of ortho treatment. You can take a look of the at the vertical position of the central incisors. There's a very important. This is a very important thing to take into consideration, because her natural size of the central incisors is not even, and in this case there are two options: to even the gingival margins, and this will mean to intrude a little bit one tooth, or to leave it, of course, the way they are. And after, actually, the third option would be to extrude one tooth to level the incisor margins. And the patient, who, by the way, is a dentist wife, is a wife of one of my referral dentists, and I would like to thank for their confidence in me. She finally decided to leave it this way. You can take a look also at the spaces between the lower frontal incisors, done at the end of the orthoclassical braces treatment. You can see that tooth 17 doesn't have an antagonist, and you all know that in the long term, this could represent a problem for the stability of the health of her joint. Please do not ever leave second molars in this position, not meeting an antagonist, because for sure you will meet again those patients in a couple of years, 5 years, 10 years, with severe problems. And you could see here that also the interincisal margins are not centered, but this is, I think, the least problem. Take a look at the spaces on the lower teeth, also between the premolars and the canines. Also, very important to observe the tooth 17 that is rotated, and that you all know the fact that if we derotate it, we gain a very important space for the distalization of tooth 16. I was telling you, my friends, that it's very important to observe, to analyze if the upper or the lower midline is centered to the face midline. And in this patient, the upper midline was centered, so we cannot move it, we cannot change it. So the only option, in order to provide enough space for the crown on the implant on 15, would be to distalize 16 and 17. we can distalize it only by rotating 17 and distalizing 16 with 1 or 2 millimeters. The guidelines for the technician were performed in 2 or 3 treatment plans, I think in 3 actually. And very, very important guidelines and aspects is to take also into consideration to keep in mind the precision cuts hooks on 24, 33 to close the spaces, to mention this aspect to our colleagues, and not to perform expansion on the upper side, because you could see on the CEF, on the teles radiograph, that her incisors and her teeth were moved too much on the cortical external bone. Let's take a look at the digital treatment plan. Let's take a look at the big attachments performed and added on the molars. As I was telling you, I'm very big fan of conventional attachments, and you can see now on the plans, on the digital plans, that as years passed, I changed my practice from optimized attachments to conventional ones. And even though, for example, the tooth root attachments on the lower 43, I kept it. It's because it didn't need a very big change of the position. It needed the closure, the closure of that space, but it wasn't a big one, because otherwise I would have put a conventional vertical one. And this is the end of aligner treatment. And we can see the rotation of 17, we can see the space for the crowns, and the whole criteria that the prosthodontics set for us at the beginning of the ortho treatment were all accomplished, because as you can see also on the distal side of the space of the distal side of the implant on 22nd is 1 millimeter, that the prostho told me it's enough for the crown. And here is the wax up with those type of crowns that I was mentioning, the screw retained IPS IMAX implant crown. And in order to have not only a maximum of aesthetics, please imagine that if the canines were maintained on that position, it wouldn't have been a final functional smile, a functional bite at the end, because she had abrasion, she had uneven width of the canines, of the upper canines. So for a maximum outcome, both from the aesthetic and functional healthy point of view, in the terms also of stability, we decided to perform also IPS MX veneers on the upper canines. This is a mock-up, the testing of the final smile. This is the midline center. The midlines are not quite center, but much better, in a much better position. Of course, every time my colleague analyzes the occlusion, both from the dynamic and from the static point of view, the canine guidance from in the lateral, in the extrusive movements, and those veneer with a minimal invasive preparation on canines are performed. The analog impression was done not because we didn't had a scanner, not because we didn't embrace the digital workflow, but because this is a protocol for refractory dye veneers. Analog transfer abutments you can see on the incisors, on the implants, but for keep in mind that for refractory dye veneers, it's very important to it's more precise actually to do an analog impression. So this type of impressions are not not dyed, have not dyed again yet. This is the final aspect, and it's really amazing to see the natural outcome. And if you could test, I don't know, your friend or maybe your colleagues, I'm sure it would be a hard time, a hard job for them to see where those crowns and veneers were put and where are the natural teeth. White and pink aesthetics is the job of our colleagues, of our referral dentists, of our prosthodontics, because they analyze and they have their criteria of natural teeth aesthetics, of form, shape, texture, of course, and most of all, papilla's conformation. And please don't forget every time to have a discussion, a consultation. It doesn't matter for how much, half an hour, 1 hour, all three of you, ortho, patient, and prosto. I know that most of us work also with referral dentists, and it's time consuming, but in my opinion, it's very important to have this type of analysis and evaluation. Please take a look also from the left side, and you can see here the crowns, the veneers, and of course the aesthetics on the aesthetics of the crowns on the lateral incisors is not a satisfying one, but it's only from the occlusal aspect, because as you can see from the anterior side is really nice, is really beautiful, and the change is amazing. I think what we achieved in 10 months is a transformative, is a life-changing process, because 10 months ortho liner treatments, 1 month of prosto work, well, it was bearable and acceptable in order to fix what unfortunately was done with braces treatment. And I don't know about the time. If you have questions or if you want to move to another case, I don't know what all of you are thinking about, or if my colleague from Smart Aligner Service can help me. Please tell me. Of course, from my perspective and from my point of view, I like to share as much as possible. And if you agree, I can move to the next case, because sometimes things happen the other way around. Sometimes patients go to our colleagues in order to have veneers because they are old fashioned, because they want to change the color, the size, the shape of their teeth. But because every time we doctors, generally speaking, not only orthodontists, but endodontists, surgeons, we think of the healthy, non-invasive outcome. We have to be honest and sincere with our patients and tell them to follow the best healthy option and not the one that they came up with or the one that they may desire and wish for. So this was the case for the last patient I want to talk about, a female of 30 years old with lack of big asymmetries, very, very beautiful, with a low teeth display and with upper teeth retroverse, a convex profile, normal chin, and a very good ratio of the face floors. We can see the uneven gingival margins due to the supra-eruption of the incisors, and we can also see the big corridors. I'm sure that you can all notice the fact that the color of the posterior crowns is not a satisfying one, and you can see from this picture that tooth 16 is extruded. She had actually a deep bite syndrome with a right class 1 canine and left class 2nd on the canine, with a lower interincisal line deviation to the left, and of course characteristic problem we face in this type of patients, a deep curve of Spee. On the occlusal surface, on the occlusal view, we can notice the dental abrasion in lower front and slightly crowding, which is a very helpful aspect, a very helpful situation. The diastema, the missing 46, the extrusion of 16, as I was telling, and the mesial incline 46 and 47 and 48. From the OPG, we can happily observe the favorable teeth implantation and the missing 14, 24, 36. The wisdom teeth are present, and 47, as we can again observe, they are inclined 47 and 48. The measurements done in this type of program for the tele-CEF tell us that she's a normal divergent, and that she has a very proclined, that her teeth are proclined, not too much, we can still procline a little bit. I moved on to the intraoral scanning, and although I mentioned here all the advantages, I'm sure you all know the fact that we can benefit from the accurate, fast characteristic, and most of all for the outcome simulator and progress assessment. And these are the most weighted aspects of the biomechanics for this type of problem of the deep bite. From the third, from the three dimension, the transversal one, very important to put the and to achieve the expansion on the posterior bilateral sectors, to have that zero final torque, which is observed, of course, accordingly to the occlusal plane, to the occlusal level, to have the tooth axis perpendicular to the bone, very important in the vertical dimension, to perform the absolute anterior intrusion that is done with the help of IPR, not too much the lingual root torque, done simultaneously with the intrusion aspect, with the intrusion movement of the teeth, of the lower teeth, and the reciprocal posterior extrusion. From the sagittal dimension is very important to achieve the incisor proclination, done of course also with the second molar compression, and be aware to have no contact between the bone and the root, not to move them too much from on the frontal sides in order not to have gingival recessions on the long term. How is achieved the leveling of the SPEE curve with lower incisors proclination, with minimal IPR, as I was telling, with overcorrection, very, very important, and with achieving at the end heavy interocclusal on the posterior sectors, and with a specific attachment. Here is the digital treatment plan, the initial proposal, and here are the changes. Very important to add the rectangular vertical attachments 4 millimeter on the central incisors to perform IPR as needed, because as you can see, the shape of the central incisors will not enable us to obtain a very beautiful smile at the end, because some small spaces will occur at the incisal edge. So it's much better to do it in the last set of aligners, of course. To open the space for the implant 436, I told you I like to share everything, also my mistakes. Of course, she doesn't need to open the space on 36. It was on 46, but of course I corrected my mistake. Very, very important to keep in mind, the frog protocol helped me in achieving the absolute intrusion on the lower frontal segment. Of course, it has its big disadvantage of consuming a lot of time and aligners, but it's a very predictable one, a very efficient one. And this is a comparison between the initial and the final clean check. "56 aligners, one set, 1 year and 8 months. And the comparison between the real and the digital, the final, I want to say, and the final in the digital set of digital treatment plan is almost the same. Of course, as I was mentioning, now I would have done, I would have more tried to convince the patient to do the second set of additional aligners, the second set of aligners, in order to improve the midlines, but she didn't agree. She was super happy with the result, and you will see why. Not only from the occlusal aspect, of course, because it's the last thing they take a look at our patient, I mean. Now, I would not use that those bite rams. I don't actually use them, not anymore. And maybe some other time I will explain why. And now we can see the pre-post orthodontic preparation for 46 achieved, of course, with the parallel roots. That is the ideal position for the surgeon. This is the tele at the end, and you can see that the proclination was achieved with a 91 value, and I think is not that much in order to face the problem of gingival recessions. This is the comparison between the initial and the final result. And we can see that, curiously enough, she didn't want veneers at the end. So this is why I was telling you at the beginning of this case that sometimes things go the other way around. She came for the prosto treatment. My colleague sent her to me to correct the bite, to correct the position of her teeth, to prepare the space for the implant. And let's take a look. Why do you think the prosto colleague sent her to me to perform the ortho treatment? Because if she would have agreed to pass directly to the prosto treatment, her smile would have been, in our perspective, worse. Why? Because she has these spaces between the incisors, especially because the debite would have been increased, not decreased, would have been increased, because when in the prosto treatment we widen the size of the teeth, we have to increase also the length, as you all know. Let's take a short break, excuse me for coughing. So the deep bite would have been increased, and this is not healthy outcome, healthy result. So the prosto, I repeat, the prosto colleague sent her to me, and after the ortho treatment performed with aligners, not with the braces, because with braces, I'm sure she would have passed to the prosto treatment. Why she was that happy? Why she was that convinced that it's the end of her smile transformation? Because now, as you can see, the buccal corridors are wider. The color, of course, is whiter because she did a whitening, but the whole aspect changed. Now her incisor display is bigger, and she was really, really happy with it, and of course us. My last message to you is to always treat the problem, not to sell, not to sell aligners, to always think of the best outcome for our patient, to put yourself in the patient's shoes. And I want to thank you again for your time, your attention, your invitation, of course, and for your extra motivation to recover faster. And this is my last final advice, let's say. Please respect the physical boundaries that your body puts you or signals you. It is very important. Otherwise, you will end up like me with with an almost 2 weeks flu. Please now, all your questions and
thank you very much, Elvira.
all your doubts. I'm waiting.
In the chat, so you can answer it, please.
Oh, Costa. Sorry for coughing again. Greetings from Greece. Well, greetings to you, Costa, also. I will be in Zakynthos in a couple of months, at the end of June. I hope to see you. I don't remember if you are living and working in Rhodes or in Zakynthos, but it would be lovely to meet you. Hello, Statis. So honored to have you with us today. It means a lot to me, honestly. So a big hug to you and love. If I use Smart Architect for the mockup, now I'm using, but for the cases I showed you today, of course, they are not all my cases done with the ortho and prosto parts. At the beginning, I did not use it. And yes, you are right. You understood well. Yes, I could say that all my multidisciplinary cases multidisciplinary cases for prosthodontics are finished with one set of aligners. And I don't want to brag myself, but you can all do this if you achieve the most important functional criteria that the prosto or your colleague tells you to, or the one that you fix, that or the one you talk about at the beginning of the treatment. Communicate with the CAD designers by calling it virtual overjet. Yes, or like this. I wanted to make sure that this aspect you will tell your colleague or technicians from not only from my point of view, but also from the point of view of my colleague is the biggest, is the most important aspect to do, because otherwise you could not finish with only one set of aligners, because he would not be able to accomplish the width of the ceramic, and the strength wouldn't have been achieved. And imagine what would happen if after paying a lot of money, after 1 year and a half, your patient would come with a broken veneer or crown, not to you or to your colleague, but it's the same thing. And you could all see that it wasn't the case for my patients, and because I followed the rules that I told you all about. And there is also one other aspect, that you could not achieve all of this in this treatment time for this duration, because your colleague could not do the minimal invasive preparation in one appointment. So this is other important aspect to think about. I like the intraoral photos, great quality. How do you get such a clear photos? What kind of camera mirror holders do you use? Tips very appreciated. My dear colleague, hopefully friend, Mahmoud Wagbi, I invite you to my clinic in order to see it, or if I will have the opportunity or invitation to talk to you about this, I can share all of the photos and maybe make a video about it. What do you say? For the case with implants before ortho, did you consider using implants as absolute anchorage for more predictable results? Yes, it's a very, very good idea. And actually, this idea was, I learned of it so many years ago, 7 or 8 years ago, from Dr. Domingo Martin, who told me this type of idea of a way of solving the problem by using the implants and the crowns, of course, the provisional crowns, to put the provisional crowns after a couple of months, 4 months or 6 months. That depends on the approval of the surgeon. Why 6 months? When bone addition would need it, would have been performed by the surgeon. Of course, we need to wait for 6 months, and if I remember well, there are 9 months for the process of sinus lifting, for the sinus lift. And yes, I could have used it. Actually, I did not use it because I wanted to satisfy my patient to start the treatment, to start a change as soon as possible, and not to put provisional crowns and then to start the ortho treatment and then to change the provisional crowns, because that would require more time, more money for her, of course. This is life. And as you remember, 47 was that much inclined. And even though it would have been a process to straighten it with the aligners, still that process would happen in this type of space between provisional crown on 46 and inclined 47. A lot of food or food infection would happen, and I wouldn't want to risk to jeopardize her the health of her gums. and to add an extra type of treatment with the help of the perio, with a perio colleague. Why vertical on 11/21st, not horizontal? Wow, a very good question. Please try to use vertical attachments on whenever you want to close spaces, and you will see, dear Costa, that those spaces will be super fast closed. They're very, very efficient. Let's see. Thank you very much. Thank you very much. I really, really appreciate the fact that you like it, and trust me, it was a process. It was so many days of thinking how I can tell you my experience, and I'm really, really glad that I can help. Whenever I can help is my satisfaction. Why you don't use bite ramps on the upper jaw? Because I'd like to explain this some other time, but the main explanation is the fact that whenever this was actually my mistake in the beginning, and that this is why I'm saying that maybe some other time I will show it to you, that if you don't analyze very, very well the moment of putting those bite ramps, please keep in mind that you have to analyze very well the moment, I mean the set of aligners when you put those bite ramps on the upper, because otherwise you will end with an error, with a big mistake of moving the lower jaw more backwards, and you don't want this. Very nice presentation. Thanks, my dear Valeria. You are so kind and awesome. I send you all my love, and I really appreciate that you are here with me. It means a lot. Do you use TEDs on your practice? Yes, and I love using TEDs whenever it requires. I'm using, as I was telling before, dental implants for Anchorage when I can, whenever I can. But of course, with aligner treatments, I use them during aligner treatments. This is an extra benefit of aligner type of treatment. But if you mean about the ortho TEDs, the temporary anchorage devices, yes, the ortho TEDs, I use in 95% of my cases with TEDs, I use the benefit system, and I will gladly share my experience and knowledge about this very creative, very innovative type of system, not because it's German, but it's the whole truth. And I can demonstrate whenever I will have the invitation that it's very simple, very easy, despite what maybe some of my colleagues think about it. Great, thanks, and thanks for the nice presentation. Lots of love, Ella. In the case with the missing 46, would you treat a similar case with closing the space instead of opening with aligners? No. I never. Yes, I never. I was thinking about. I never tried to close the space. And this is another knowledge, another thing that I learned from one of my mentors, big love to Domingo Martin, that tells us that whenever we are trying to mesialize the back teeth, the back molars, we are not facing with not only with the problem of the time, of the effort, but also with a very big, let's say, a risk of not closing enough the space, or very, very important, to move the teeth, the back teeth, in an inclined position. And you all know that if the back teeth are inclined, they will end up in premature contacts or interferences that will end up in an unstable occlusion and in a pathological occlusion. And this is the worst thing that we could obtain for our patients. And I always think about the medical aspect, not on the aesthetic criteria or on the wishes of my patients. I admit, of course, I try to do a compromise to satisfy everyone, but the most important aspect for me is the medical, the healthy aspect of my treatment. Thank you for your nice presentation. Wish you a quick, healthy recovery. I hope so. Lots of love, and hope to see you soon or with other interesting topics. I hope I will receive a lot of messages and questions on my email address and on my Instagram address. You are all invited there and to my clinic and to Bucharest, of course, as I was telling. Lots of love and have an amazing week with health, and please do not forget to respect your body and the signals that your body is telling you. Lots of love.